At the end of the last class, I mentioned we're going to tie up marital counseling and move on to family therapy. The one thing I want to mention about in marital counseling is, the examples I've been giving you have been obviously relationship oriented, and that indeed is usually the reason you do this kind of therapy. But there are times when people present with a very specific problem in the relationship. The most common being what we would call sexual dysfunction. And it's really important here that the therapist understand there certainly is more than one possibility. For example, a couple comes in, especially if the relationship is fairly new, and they're not having a satisfying sexual life. It really may be an issue of technique. That is, it really may be that they haven't talked to each other enough, that one person doesn't communicate to the other about what is really pleasurable for him or her, where the person likes to be touched. They may not be taking enough time in foreplay. They may not be comfortable enough even to be able to function as well as they normally could, because they're just too eager to do well. And so therapy may be really teaching them how to slow down, how to learn from each other what really would be very pleasurable, maybe to hear from each other something that one is doing that actually is a turnoff. So the person will stop doing that. To learn perhaps something that is a turn on, so the person will be doing that. And it's not unusual that sometimes when you just have that level of communication, people find their sexual life improves a lot. First of all, they get more comfortable. Secondly, they actually communicate to each other about what would be pleasurable, and also they get rid of anything that the other person doesn't like. Now that's one level of intervention if people are having difficulty sexually. It may really be that people are having difficulty sexually, and it has nothing to do with technique. It has everything to do with the fact that the couple is growing apart, that the sexual dysfunction is simply a manifestation of the entire relationship is dysfunctional. The reason why the people are not having a gratifying sexual life is they've stopped liking each other. They've stopped feeling good about each other. They've stopped feeling intimate about each other. And if you focus on their sexual life, you probably will miss the point. Because you really do not want to be working with someone or with a couple on how they can perform better sexually with each other, when what you really need to be working on is that you two have grown apart, that perhaps you are angry with each other, and that the lack of sexual gratification may simply be a manifestation that I wouldn't want to sexually gratify you because I don't feel I want you to feel that good. In fact, I want you to know I'm angry with you. So we're going to be sexually active less, and even when we are, I'm not going to be terribly sensitive to you. And in fact, I'm so angry with you, I hope you don't have a good time. Much of that, by the way, can be unconscious. People may not be as aware of those kind of angry feelings as I'm making it, but the dynamics are that internally that really is how the people feel. So in the latter case, you really want to get the people to talk not about their sexual feelings so much as about their anger, about their disappointment, about their fear that the relationship is going to break up, or maybe that it already has ended. And if you miss that, and you spend time just dealing with the people as two sexual people and what they can do to make their sexual life better, probably you'll get nowhere. So making that distinction, is very important. Now, we're going to move on then. We're going to talk about family therapy. And as you can tell, of course, family therapy is an obvious outgrowth of marital therapy. I mean, all you're really doing is involving more members. Family therapy is usually thought of as mom and dad and the children. However, in today's world, family therapy has become much more complicated than that. People talk about generational family therapy. And generational family therapy really means that you might have the grandparents, in. the treatment, the parents, the children. Just, in other words, who are the significant people in the group that seem to be players and seem to be part of what is a problem? So you could have the grandparents. You may not have two parents in family therapy because one parent may be responsible, that is the couple may be divorced, one person may be responsible, having a lot of difficulty with the children. The other parent may not even live in the city or the state. So you might just have a parent and the children. You may have, in really complicated situations, if you have a blended family where you've got mom had children by another marriage, dad had children by another marriage, but all those children live with this mom and dad. But there are problems between both sets of children and between both sets of children and the parents they're not living with. So you could have two couples, all of whom are parents to some of the children, and two who maybe perceive themselves as parents to all of the children. And you could have two families, but they've now become one family to some extent. All of those kinds of conflicts that might arise are legitimate for family therapy if the person doing family therapy feels that that's the best way for us to intervene. The key in this, usually in family therapy, is you need to make certain everybody sees themselves as part of the treatment. Where that sometimes becomes difficult is, there are a couple of examples. One of them is a child, it was the first person referred. As child's having difficulty in school, child is disruptive in school, child's disruptive at home. This is creating problems. Maybe the child even did something antisocial and got involved with the police, or the child has been using drugs. But the child is kind of like identified as the patient. And so the family is here to help the patient. A good family therapist quickly gets people to see that actually we're all going to work. We all have problems, and we're all going to work on seeing how our family can work better, how everybody in the family can become more effective, how we can appreciate what each of us is feeling, and you take the pressure off the so-called identified patient or identified client, because if you don't, you can keep the same pathology going. That is, it may be one of the reasons the child is acting out like this is the child feels, I'm not loved in this family. All my brothers and sisters get more attention than I do. Mom is too busy to pay attention to me. Dad's never around. And when they are around, they're always being nice to so-and-so and this other person. And the only reason I'm getting attention is because I'm creating some problems now. And if I would just stop creating problems, they could go back to the way they were. Guess what? The chances are this kid is not going to stop behaving badly because he's now getting attention. So you don't want to identify and keep the whole focus on the youngster who's acting out, because for the first time it may be the kid's actually getting some attention. So what you do with him is you try to get him to talk about why is he acting out, which is not easy often with youngsters like this. But you want him to talk, but you also want the others to talk, because other members of the family also have things that they want to discuss, things that are problematic for them, things they would like help with. And you want to get an environment in the family where everybody tries to be facilitating for everyone. Now I mentioned, that's one example then, is the kid is the identified person. Sure, Mr. Opuni?
I have a question. What do you do in a case where, like, let's say, for example, there was a loss of a loved one in the family? Would the therapist have the family as a group, or would they see each family member individually, or how would that work out?
Okay, there's a loss of a loved one in the family, and I assume what you're saying is that has really created a lot of difficulties. There's no reason why you wouldn't see the whole family together. I mean, if the family is experiencing the loss, and let's say there's a lot of disruption in the family because of the death of this person, I think the goal, of course, would be to first of all find out what the loss of this loved one has meant to each member of the family, and you'd want to get the members talking about, how they felt. You want to be sure that people have been able to mourn. You want to be sure that people have some understanding about what their fears are now, that there is no mom anymore, or there is no dad anymore. And last week, or a month ago, there was. And you want to get a sense of, what kinds of new problems have, happened because of this. Let's say there are 6 children in the family. Dad died. Mom got very depressed. What the kids may end up telling you is they feel like they lost both parents, that they're orphans. And one has to be sensitive to the fact that, mom is mourning. This was an incredible loss to her. She feels overwhelmed maybe by having all this responsibility for 6 children. And so you want to allow her to talk about her feelings, but you also want the children to be able to talk about the fact that they feel like their family is gone. And you want to, help each of them to realize how they can now help to make up for the loss of dad, and how they can help mom, and how mom can be more present to the kids. And you let them solve it. That is, the focus is on letting them tell you how this could happen, and then encouraging them to make it happen. So you could take, in fact, you probably would do better, to work with the whole family. In the situation you described, though, it wouldn't be unusual if it was actually the case that I indicated, like the dad died, mom is suddenly the sole breadwinner, and perhaps only the father worked. So now they've got a real issue about income and things like that. The mother might be the person who is first referred. And you might want to see mom for a few sessions to really understand, the fears that she's living with, the anguish that she's going through. I mean, she may really have loved this man very much, and so the loss is tremendous. And she may be saying things to herself like, with 6 children, nobody else is going to want to marry me. I mean, I'm going to be alone. And I, have not worked. And I don't know that I can even get a job. But if I can get a job, it may not at all, generate the income that my spouse, brought. And the children are going to have to change. Some of the older children are going to have to start working. I feel guilty about asking them to work. I mean, lots of things can come up. But if you begin to realize that the children are also unresolved, after you give mom a chance to tell you where she's at, and you get a good sense of what mom can do and what her strengths are, and the pain she's in, then you may want to bring in the children, get her to agree and say, well, why don't you bring the children in, we'll all talk. And then you really get the dynamic in the family of what is everybody feeling, what kind of loss was here for everyone, what kinds of things can we do to make things better. Now, what is important in this example you gave, and that sometimes it's hard for a young therapist to realize, is when you get that family together, you may find in the early sessions, you're just going to hear a lot of rage. That is, everybody is angry because dad died. Everybody is angry at dad. Why did he do this? He died and left us. Now, when that comes out, you have an accompanying feeling, and that's people feel guilty. They love dad. He was a good person. And now they're angry with him. They feel abandoned. They feel frightened. They won't be able to make it without him. So you get lots of intense feeling. And it becomes important to allow the family to vent this real pain that exists. And it also becomes important when you realize that, we can now kind of all admit that this loss of dad was a shock, that it makes us feel vulnerable. And you want to get past the rage. You don't want to spend a lot of your time focusing on maybe rage is not such a good thing. You want to encourage the rage to come out so people can realize they're enraged. But then you want to try to get them to understand that this rage is really their way of expressing they're very scared. They don't know what to do. They were totally unprepared. And if you think about it, when a parent like that dies suddenly, people are unprepared. And so, you want to help them to realize they have resources. Internally, there are things they can do. And you want to be realistic. Life will change. Probably the older children are going to have to work. And you want to help them to come to grips with how they can do that without giving up their other aspirations of finishing school, of being socially involved with others. So it can be a very powerful kind and a very helpful kind of intervention. And without it, you may get a family that really disintegrates. That is, if mom continues to get more depressed, feels overwhelmed by all of it, and one or two of the kids, decides to escape by getting into drugs, you can have a really dysfunctional family and not very long. And had they gotten into treatment when they should have, that is, when all of this started to happen, you might find that the kids came together, and instead of going to drugs, they actually went to a job. Instead of, just withdrawing from everyone, they actually started to become more supportive of each other. So the intervention can be incredibly important and helpful, and it can change the whole direction of a family. So it's a very good question you raise. And you probably would get further if you see them all together. Okay. Now, the other thing that differs in family therapy from, say, group therapy, you got two groups. But in family therapy, the group goes home together. So you have the group functioning all the time. And it's interesting, sometimes if you give them a task, like, the older kid, who is not so older, I mean, the 8-year-old is always slapping the 6-year-old around, and you come to an agreement, the 8-year-old is not going to do this anymore. That when the 8-year-old gets upset with the 6-year-old, the 8-year-old is going to tell the 6-year-old what is bothering him, and they'll try to work it out. But they go home, and they're not home a few hours, and the 6-year-old does the typical hostile thing he's been doing, and the 8-year-old hits him. Well, you come in the next session, first thing that happens is the 6-year-old says, the 8-year-old didn't do what he said he would do. In fact, we left here the last session, and an hour after we left here, he hit me. And you then, you're in the position where, you could, if you're a bad therapist, you could be thinking, I thought I told this 8-year-old not to do this. But instead, you say to the 6-year-old, why do you think this happened? I don't know why it happened. You told him not to do it. And so you let him talk. You let the 8-year-old talk. You find out that, you didn't really make clear enough that actually, both of you have to change. That is, you have to stop hitting your younger brother, but you, the younger brother, have to stop inciting your older brother to hit you and doing things that are very distressing. And often, that kind of repetition goes on. But what makes it helpful is that since a group goes home, and since they had some direction about what they should do, kids report back graphically what happened or what didn't happen. And so you can work from there. Now, family therapy also can be very helpful if you really do have a member who is more vulnerable than the other family members. And this happens, for instance, in a family where one member of the family is schizophrenic. Being schizophrenic is a very vulnerable position to be in life. And because one child is schizophrenic does not mean that anybody else in the family is schizophrenic. And it doesn't mean anybody in the family is responsible that this child is schizophrenic. But we do know some things about schizophrenia, and one of the things we know is that people tend to become more psychotic and to behave more bizarrely if they're under a lot of stress. So if there's a lot of stress in the family, you're likely to have your schizophrenic person behaving more primitively, acting more bizarrely, and then if the person has been given antipsychotic medication, which can be very, very helpful, but the person is not taking it, you end up in a very bad situation. You've got the person who is schizophrenic. They are likely to become more symptomatic because they're not taking their medication, and they're likely to become even more symptomatic than that because they live in a very stressful environment. When the family can be very supportive of this person, and some, really in a very caring way, try to make sure the person takes medication if that's necessary, goes to therapy sessions or goes to any other kind of intervention that's been arranged for the person. When people get distressed in the family, they realize perhaps I should not let out my distress when, directly, certainly, to this member because the person can't cope with the kind of tension that gets raised in the family. You can do a lot. And in this case, of course, you know, in a way, you have an identified patient, and you do have an identified patient. But that person is a real person. And that person's behavior does cause everybody else in the family to act or react in certain ways. And there's nothing to keep you from helping the patient who is schizophrenic to realize maybe there are some things you shouldn't do. Maybe there are some things that you do that really provoke other members of the family and add to the stress. So you have some responsibilities too. But certainly, in the case I'm giving you now, you do have a disproportionate emphasis, you almost can't help it, on the person who is schizophrenic. And everybody in the family kind of knows that this particular young person does have problems the rest of us don't have. And this person does need more structure, does need more support, and maybe there are some things we can do to help with that. Now, let's see. What did I... Okay. Okay, I guess I didn't put this in here. Earlier, I know where. Yes. Earlier I mentioned that the real alternative psychotherapies are psychosocial rehabilitation, prevention, and community psychology. Are any of you familiar with what psychosocial rehabilitation is? It's not that I would think you would be, but I just was curious if anybody, okay. Psychosocial rehabilitation is a form of intervention, and almost always it refers to the treatment of the seriously mentally ill. And what happens is that people who become psychotic, people who are schizophrenic, they get hospitalized. When they leave the hospital, they aren't really ready to return to a home if they have one. And they may not even have a home to return to. So what happens is they're sent to what are called psychosocial rehabilitation centers. And these are places where a milieu is created to help a schizophrenic person, or perhaps a manic depressive person, to return to society and to function in that society. And the premise for this is that the hospital, especially today with short stays in the hospital, doesn't have the time for the person to be prepared, to cope with the environment they're going to come into. So there has to be a place where they can be safe and they can be taught. Now, these centers have been extremely helpful. For example, a client may enter such a center, and there are all kinds of things they need to learn. They need to learn some job skills, for example. After all, if they have no family to go to, they have no income, and then they're young, which is, by the way, typical population we're talking about, they need to learn something. May not be highly skilled labor, but they do need to learn how to work. They need to learn how to live independently, or maybe to live in an apartment with another person, or perhaps to live in an apartment building where they would have their own apartment, but several of the apartments would have people living in them who had had schizophrenic experiences and were now trying to be rehabilitated. You'd be surprised at the basic skills that some schizophrenic people need to learn. They need to learn how to shop for food. They may need to learn how to care for their clothing. They need to have a kind of an organized plan for how they're going to go about taking their medications. And in a psychosocial rehabilitation center, they can learn from other members of the community, that is, other schizophrenic people, what they do well. That is, they may do things that actually endear them to other people. They should learn what those are. And they need to learn what are they doing that annoys people, causes people to reject them, push them off, or not be a cooperative member of the society. Then also, the psychosocial environment often helps people who are schizophrenic to become more sensitive to what are the experiences in their life that cause them to become psychotic again. Now, the most obvious one, by the way, is they stop taking their medication. And when they stop taking their medication, they often become symptomatic. But there are other things that happen where they get themselves into very stressful situations, and the stress leads them to start behaving more bizarrely. It leads them to start operating in a delusional way. They may regress enough even that they begin hearing voices. And the stress factor cannot be overemphasized. You really have to try to create a low-stress environment for people who are this vulnerable and have these kind of difficulties. And I remember one time a schizophrenic patient who had a PhD was describing the experience of becoming psychotic, and it was a wonderful example. In his case, I don't think I've used it in this class yet. He was on a plane, and he began hearing voices, and he knew it. I mean, he knew these are voices. He knew he was becoming psychotic, and he realized, like, this is what they mean. I hear this voice. I know this is psychosis. I know there's nobody here. But, it's kind of interesting. The voice is telling me to move. The guy got up and changed seats. He changed his seats and finds that he kind of like that. Now his voice is telling him, change seats again. He changes seats again. Well, he begins to realize that when I first got on this plane, nobody paid attention to me. Now I've changed seats a couple times. People are noticing me. I've become a person. I'm enjoying this. He changes seats again. Then the voice says to him, open the door. And he thinks, I bet people pay a lot of attention to me if I open the door. He goes up to open the door. Cabin attendant sees him, grabs him. They put him in handcuffs. When the plane lands, they arrest him. And he describes this vividly. Now, anyone who just saw him, they would say, we had this crazy guy in the plane. I mean, this guy started jumping from seat to seat, and then he tried to open the door and jump out. And people might even say the guy was suicidal. Completely would miss the point. The idea was you have this very isolated guy who stops taking his medication, begins to hallucinate, and it's pleasurable. I mean, the delusion, first of all, the hallucination of hearing the voice is something he knows is psychotic. But he was described this wonderfully. He said, but once you give into it, once you start getting into that world, it actually becomes very pleasurable. And when people are paying attention to you, and you think nobody paid attention to you before, you're getting rewarded. And when someone asked him, when you opened the door, did you intend to kill yourself? He said, well, no, I didn't intend to kill myself. He said, in fact, it never dawned on me if you opened the door of the plane, you would die. It's an incredible world that people get into. And this is not at all an atypical example I've just given you. What's atypical is that the guy had a PhD and was so reflective that he could actually tell you at a time when he wasn't psychotic what it was like to be psychotic. But in terms of working with people, this is something that happens a lot. Now you get a group of these people in a psychosocial rehab center. You can imagine how important it is that you try to get all of them, if they need medication, to take it. And if they are going to some kind of psychotherapy, and almost always you want them to be in some kind of therapy, that they go to that treatment. But the real key in psychosocial rehab is that they deal with the person's real life. That is, they deal with the fact that you have got to find a way to be able to shop, to clean your apartment, to make your bed, to organize yourself around taking your medications, to find a way to work, and to find a way to relate to other people in the building that doesn't scare them. Now, the outcome of a good psychosocial rehabilitation program is that you're really empowering people who are very vulnerable and don't believe they have much say about their life. That is, they don't think they can take care of themselves. They don't think they can take care of an apartment. They don't think they can get a job. They don't think people will care for them. In fact, people are scary. If you really work with psychotic people, the one thing that you realize is that they feel very frightened that other people will harm them or do something to them that will be terrible. So you want to try to work with them to show them that, no, there are steps you can take that will allow you to take over your life. That's a very delicate, difficult thing, but that's what psychosocial rehab centers do. And so when you have a lot of activities for the person, you have to be able to pick up what can this person do well. So let's say, for example, you're going to have the person get a job. You don't want to give them a job that you know will overwhelm them. So let's say, there's a job open for a person who's going to be the information officer at a mall. You go up to a desk and you say, where is this? And the person says, this is over here, and this is over here. If you were to take someone who had recently been psychotic and give them that would probably overwhelm them. You got all these new people coming, first of all. Everybody that they see is somebody they don't know. And then they're asking them technical questions like, where is this store? Where is that store? Where do I go, to find nuts and bolts, Where do I go to find shoes? Where do I go to find baseball caps? That's just way too much stimulation. On the other hand, if the center needed a night watchman, a person who would just walk around and see that things were safe, wouldn't run into a lot of other people, has a very structured job, like, night watchman, they give you a key, and, you walk around the center, you put your key in, and it says, you did visit this store, you did visit this store, you did visit this corner. For some people, they could do that. And so they experience, I am now employed. Now, it may be that they could only do this for a few hours, so they would have to start the job and they couldn't do a whole shift. But maybe they could do a few hours and they get paid for it. And so they begin to feel, I'm a productive person, I have a job. Somebody asks me, what do you do? I can say, I'm a night watchman over at the mall. And now I have some money to spend, and now I've learned how to go out and to buy some food. And you want to gear all the activities so that's the way the person feels. And this is very delicate work. The people who do this, and many of the most skilled people are social workers or mental health workers. But those who do this well make a huge difference in the lives of these people. And why the work is difficult is you find many of the people will relapse. That is, even though you get them to the point where they can do some of these things, one of the key things we've always found in working with people who are seriously mentally ill is they stop taking their medication when they really need it. And then they begin to be like the patient I described you. That is, they begin to hear the voices, or they begin to have delusions, and they actually find that they don't want to get rid of them, so they don't take the medication. Then everybody begins to notice how bizarre this person is being, and they end up back in the hospital. Now, to try to help with all of this, psychosocial rehabilitation has developed a concept that's called case manager. Case manager is really key, because the case manager is the person who, first of all, kind of determines what is a possible plan of action for this patient. That is, how can we set up this individual's life so that they will, in an organized way, first of all, learn to relate to other people in the center, will be able to go out and interview for some job they're capable of doing, and if they're not, is there some way we can send them to some place that will teach them some skills so that they will have the skills to do a job. And the case manager's person also gives out assignments that helps the person perhaps to go with another patient shopping. So the person learns to shop, the person learns to take care of their apartment, all of those kinds of things. Now the case manager is also the person who wants to see that the individual gets to therapy at the mental health center, and this case manager wants to make sure the person is taking medication And that means they want to be sure that the person is actually getting the medication so that they can take it. So if the person doesn't have money, you want to be sure that there is some place that will dispense the medication free to this person so that they will take it. The case manager becomes, key in organizing all of that. The case manager then also becomes the person who, if the caseload is not too heavy, sees the people often enough that they begin to recognize when someone is psychologically deteriorating. That is, they begin to recognize this person is now becoming symptomatic. It's obvious he or she has stopped taking their medication. It is obvious this person is becoming psychotic. We have got to do something to intervene. And so the case manager may sit down with them and say, are you really taking your medication? Because I don't think so. And the person may well admit that they're not. And the case manager can say, well, what could we do that would help you to start taking it again? And if you're effective enough and you're able to get the person to start taking it again, they'll probably not have to be hospitalized. If they don't cooperate, you can almost be sure they will end up being hospitalized. Now then, there's a concept called prevention. And prevention isn't necessarily prevention in the way we usually think of it. For example, let me just, and I'm going to kind of go backwards. There's primary, secondary, and tertiary prevention, but it's easier to describe them in the other direction. Tertiary prevention actually refers to interventions that occur after a person is seriously mentally ill. And so this term actually includes such interventions as psychiatric hospitalization or referral to a psychosocial rehabilitation center that I just mentioned. So here the term prevention actually refers to helping a person avoid relapses. You're not preventing, for example, mental illness or a mental disorder because this person is already very troubled. The tertiary prevention refers to someone who's already very troubled, but you are trying to prevent relapses. And you are using the most extreme and therefore probably the most expensive interventions. That is, you're using things like hospitalization or psychosocial rehabilitation centers, which may be 24 hours a day. I should have mentioned, by the way, with psychosocial rehab centers, some actually have their own hotels or their own apartments so that they arrange the living situation for people. Some of those psychosocial rehabilitation programs don't have the living environment, that is, they don't control it, but they have ways of getting people placed at inexpensive hotels or inexpensive apartments. But as you can see, we're always talking that in tertiary prevention, you're talking about very costly interventions. Now, when you get to secondary prevention, it refers to really to two populations. One population is those individuals who are at risk for developing a more serious psychological disorder or developing a serious disorder because the conditions around them lend to that, and historically we know that. For instance, children of alcoholics often have significant psychological problems. Individuals who are living in very troubled families. Or the high-risk population are people who have unrealistic expectations for themselves that perhaps developed in the family. Now the second group, and this is the group we most often think of when we think about secondary prevention. These are people who recognize they have a difficulty and they seek psychotherapy or some other intervention as they recognize that their problem is becoming unmanageable. They've lost their job, a relationship is broken up, something important has happened. And so these people normally are in psychotherapy in some kind of outpatient setting. They either go to a mental health clinic, go to a private psychologist, psychiatrist, social worker, etc. And secondary prevention usually is more focused on outpatient treatment. It's therefore the intervention is less expensive, but the person already has an identified problem. And when we talk then about prevention, the prevention you're talking about is you don't want them to get worse. You don't want the problem to grow into an even more serious one, but you haven't prevented them from having a problem. They already have the problem. So that's what secondary prevention refers to. Now then we have what is called primary prevention. And this is really a complex area. It involves eliminating or at least modifying environments where people might have problems. It also involves building strengths in individuals so that problems don't occur. Now, the public health is usually the field that's most seen as involved with primary prevention. If you think of some examples, people get smallpox vaccinations. I mean, it's a wonderful example of primary prevention. There was a time when, smallpox was a common illness. Chickenpox is another one, measles. All of these things that we now inoculate children for. Only a generation ago, children got these diseases, and then they had to be treated. Now, in the case of these diseases, many of them, we knew how to treat the disease. So the person didn't die from these things usually, but once we learned how to prevent them, it became way less expensive. And first of all, we eliminated the deaths that would have taken place. We eliminated the time that children would be out of school. We eliminated the time the parents would have to devote to the children. And all we had to do is take the child once to a physician, or to a nurse usually, who gives the kid a shot, and the child's not going to have this. Now, that's primary prevention. That's where you have a problem, you have a solution. It's a grand solution. I mean, it takes in a whole population of people. And that's probably the best example. I will give you some others. Let me give you an example, though, going back to tertiary preventions. There was really a famous one that developed in the 1970s in Madison, Wisconsin. And it was called an Assertive Community Treatment Program, ACT. And this was a fascinating program. What they decided at this mental health center in Madison, Wisconsin, is rather than hospitalize people who were acutely psychotic, so a lot of schizophrenic patients, they would go to the patient rather than bring the patient to the hospital. Many of the people in this particular community had families, but they had been hospitalizing people because, people start acting delusional at home, start hearing voices, family gets very frightened. So you put the person in the hospital for a while, you calm the person down, you get them on medication, and you release the person back to the family. This program decided that as soon as we know there's a problem, and therefore you have to educate the families that you're available, we'll go and see the person. They don't only see the person, they see the family. Start the person on medication right away. Tell the family if this person becomes disruptive, even during the night, we'll send somebody out. So it was kind of a 24-hour care program, but they kept the person in the community. Now, when you figure that in those days, had they hospitalized the person, probably would have cost like $300 a day. Now, of course, we'd be talking well over $1,000 a day. You're saving a tremendous amount of money by treating the person in the environment in which they live. They found that people reintegrated faster by not taking them out of their environment, putting them in the hospital. They found that they saved a tremendous amount of money. But they also had to invest a lot of money. That is, if you're going to have people available 24 hours a day, and you're going to be, going out to a person's home, that's an investment of a lot of money having a staff like that available. But even so, you're still not going to spend half the money that you would have spent if you'd hospitalized the person, and you're getting a better result. This was just a very, wonderful intervention. Now, in secondary prevention, I think I've already mentioned to you that Here we're usually referring to people who go to outpatient clinics. They go to mental health centers, they go to counseling centers, they go to private therapist offices. And so the person who is doing the treatment, often it's a single person. You notice the one I just described to you, you got to have a whole team of people to go do things. And in secondary prevention, often you don't need to intervene with medication, although sometimes you surely would. And secondary prevention most often refers to seeing someone in a setting like an office. Now, primary prevention really is a problem. It's exciting, but it's not necessarily successful. There are all kinds of reasons and all kinds of problems that exist in the area of primary prevention. If you think about this, if you prevent the problem, how are you going to demonstrate it would have happened? So it often becomes difficult to get people interested in primary prevention because our focus more is, show me a problem, I'll show you how we solve it. When someone comes along and says, I know how to prevent the problem, we get suspicious of that. Then there's really not the social pressure to develop prevention programs that there is to develop intervention programs. I mean, people don't run up to you and say, we ought to develop a prevention program on this or that. There are a few things where people might say that, but normally they don't. Whereas people will come up to you and say, my child is depressed, do something about it. My spouse is upset, you've got to help us. My uncle is drinking too much. There needs to be a program to help him. So, you do get pressured to come up with intervention. But prevention, our society doesn't get into it so much. Also, there are numerous examples of where primary prevention has really worked. The public health ones I mentioned are obvious ones. In spite of that, neither the National Institutes of Health or the National Science Foundation really put up a lot of money to research things that we might do for primary prevention. And the last thing is that if you work in this field, it's probably less gratifying than if you work in the areas of secondary and tertiary prevention. I mean, when you work as a psychotherapist and somebody comes in your office and they're desolate, and you really help them to overcome that and to begin to understand that they can empower themselves, that they can do certain things, and you begin to see their depression lift, and you begin to see them functioning better, that's very rewarding. You don't get those kind of rewards when you do primary prevention because there isn't any problem that you can see. Now, in some situations where we don't have an intervention, then primary prevention becomes very important. One of the best examples, of course, is with AIDS right now. We don't have a way to treat the HIV virus that we know will make someone well. We have a way of delaying its process, etc. But we need to do things to keep people from getting infected. And so the primary prevention is developing education programs that will help people to learn to avoid behaviors that would get them infected. And those education programs may be to teach mothers, for example, who are HIV positive, don't breastfeed your child will get infected. To teach people who insist on using drugs that don't share needles, and to try to get other people to not have unprotected sex if they already have the HIV virus. Now, that's a form of prevention. That is a primary prevention in that those things will keep healthy people from getting ill. And those areas get much more attention than the areas where we don't have a known outcome. Well, we're going to stop there for today, and I'll see you in our next class.